This is our Q&A. Welcome everybody. Welcome to our Q&A. I'm Cheryll Alomai, Patient Services Manager here at the Foundation, and I'm grateful to be joined by Dr. Andrew Yeoman. Thank you so much for your time today. We've got quite a lot of questions to get through, the submitted ones already, and just to say welcome to the people who've joined us in Click Meeting, and we are also live streaming the session on our Facebook page. Please bear in mind that it is a public forum on Facebook, and you can come and join us in the privacy of Click Meeting. So just a little reminder that in these sessions, we do not provide specific medical advice. They do not take place of your appointment with your clinician. We do want to make sure that you feel empowered for those appointments though. So Dr. Yeoman will provide medical information. And so we ask people to pre-submit questions. So do that at info@pbcfoundation.org.uk. And if we've got time today, we'll have a look if there's any coming in live in the room as well. So welcome, Dr. Yeoman. Nice to see you. And will we make a start on the questions, if that's okay? Yep. Okay, so first one here I have. So someone's looking for your views on low-dose naltrexone for symptom management of PBC. If you have anything to say on that, please.
Yeah, so naltrexone is a medication that blocks something called opiate receptors, which people understand opiates as morphine and codeine-like drugs. But blocking that effect, sometimes it improves itch in some people with PBC. And it can be very, very effective for some people. And there are various treatments used for the treatment of itch in PBC, and that is one of the options for that. In some people, it can cause a slight cold turkey type response, even if you're not normally taking opiates, where you can get sweats and just feel a little bit on edge. But that doesn't happen to everybody, but it can happen in some people. So as long as people are aware about that before they start taking the medications, and usually start at a low dose and increase the dose up from there as tolerated. So yeah, absolutely can be a treatment option to treat itch in PBC, which, as we all know, is a really challenging symptom and can be devastating for people's quality of life. So it's definitely there as one of the tools in the armamentarium to try and treat itching in PBC.
Excellent, thank you for that, brilliant. So somebody else is asking, they've got osteoarthritis and they've been on Celebrex for 2 weeks, which has helped reduce inflammation significantly. And what their question is whether taking a low dose non-steroid anti-inflammatory drug, is it okay to take that to keep the inflammation at bay?
Yeah, obviously, and not party to all the different clinical information for each individual, but certainly anti-inflammatory medications like celecoxib can be helpful at improving joint symptoms. And for most people, they're perfectly safe. There are groups of people who are at greater risk of developing side effects from non-steroidal treatments. The commonest ones will be fluid buildup. It can sometimes cause gastric irritation and gastric ulceration. But in younger people, particularly those under the age of 65, they're usually safe to take long term unless they've had previous problems in that area. But if you have a history of advanced liver disease, so if you've ever had problems with what we call decompensated liver disease, fluid buildup, or you have heart disease or kidney disease that causes significant buildup of fluid, then you have to use those drugs with caution. But if you're otherwise fit and well, and relatively young, then the risk of taking those medications is not especially high, but there is a potential risk, as I say, causing GI upset and GI ulcers in anybody taking those drugs at any age, but it's just the risk becomes greater with the more other health conditions you have and the older you are.
Thank you very much, that's really helpful. Now, where somebody's asking, well, a few people have, this has come up many times, but when the brand of Urso they're prescribed changes, and any tips for conversations with pharmacists, clinician that you could share?
Yeah, this does come up quite a lot, doesn't it, Cheryl? And I think it is an important issue because although the active drugs should be the same, the delivery mechanisms for the different products might be somewhat different. So therefore, the absorption might be variably different. And so And also side effects can be sometimes different. Some people get side effects with one brand and not another. So if you've had side effects with one brand of urso oil, I will normally try another one before saying that people are truly intolerant of the urso itself rather than the other constituents of the tablet or the powder. So the general principle is to try and stay on the same brand that you've been on before. One of the challenges we've had over the last few years, for a number of different reasons, partly Brexit related, partly due to other sort of, I think Ukraine caused some problems with drugs supply and things like that. So there have been more drug supply issues over the last 5 to 6 years than there have been previously. And that can sometimes mean that sometimes some medications are temporarily unavailable. And then it's a trade-off. So preferentially, we'd always want to use the same brand. But if there is genuinely a supply issue with that medication for a period of time, then an alternative brand is not unreasonable to do, but recommendation would be to go back onto the usual brand that has delivered a given response rate as soon as is possible. The difficult thing is sometimes you get issued a different brand and you're not notified about that, or you're not told up front, and that is actually, you should be notified about that because, as I say, there can be differences in their tolerability, and there can be marginal differences in their effectiveness. So, as clinicians, we should be prescribing the same brand. I've probably sometimes forgotten and just gone more generic than specific, but I think if people have been using a specific brand, and if you go to the same pharmacist, generally speaking, you will be issued the same one as if you change pharmacies. They might be issuing a different brand of the drug. So, but it is important wherever possible to try and stay on the same one that you've been on before, because then you can expect a predictable response. Whereas if you switch brands and you lose ALP response or you get different side effects, then that just creates lots of problems you want to try and avoid.
Yeah, so sticking to the same pharmacy can help, having that conversation with your pharmacist, and actually that your clinician mentions that when they're doing the prescription, just to make sure that you get the same one. So that's really, really helpful, yeah, because it does come up.
You can go back to your clinician and ask for the branded.
Branded.
We do fall into the trap of prescribing the generics because, so we might just write ursodeoxycholic acid rather than, for the sake of argument, ursofalc. That's just one example. And if we did that, then and you've always been on ursofalc, then go back and then prescribe an ursofalc. The pharmacist then has to issue ursofalc. They shouldn't really then issue something that isn't that. Whereas if we prescribe it generically, they can prescribe different generic options.
I can see that being really helpful, so thank you for that. So this is another thing that comes up often, dry eyes. Is this part of PBC, or could it be a side effect of urso? Somebody's asking.
Yeah, it's not typically a side effect of urso, but it's not directly a part of PBC, but it's part of systemic autoimmunity. So as many of you will be aware, PBC is an autoimmune condition whereby our immune system takes dislike to different parts of our bodies, and in the case of PBC, that's our bile ducts. But there are many other autoimmune conditions that can be associated with PBC, and one of the common ones is Sjögren's syndrome, which is it's associated with joint pains, or you can get a Sicca syndrome, which just causes dry eyes and dry mucous membranes in the mouth. So your salivary glands don't produce enough saliva, and your lacrimal glands don't produce enough tears. So dry eyes can be commonly associated with PBC, either as part of a Sjögren's syndrome or just on its own. So it's PBC associated, and it's a feature of autoimmunity.
Yeah, so it's associated.
Yeah, it's an associated condition. The challenge with it is, of course, is that we don't, unlike we have several treatments now for PBC to try and directly target the immune damage of the liver, but we don't have specific medications that target the immune damage affecting the lacrimal, the tear glands. And so the only treatments we have for that really are to try and use artificial tears to try and keep the eye lubricated. And it's really important your eyes don't get too dried out, because you're very prone then to getting conjunctivitis. So the moistness of the eyeball is really, really important to facilitate adequate vision, but also when the eyeball gets dry, it's very susceptible to bacteria and viruses getting adhered to it and causing nasty infections, which can be very, very painful and very contagious to others as well. So it is important that you don't run really dry, gritty eyes, and do seek medical treatment for that. And it's usually an easy prescription with some Viscotears or some other brand to try and help lubricate the eye so you're not getting visual problems and conjunctivitis.
Who are you chatting to about that then? Is it your hepatologist? Is it your optician? I was wondering.
Opticians can do that if you're already in touch with an optician. GP will often deal with those sorts of issues because they're not directly associated with your PBC. But if it's if you're in the middle of your consultation with your hepatologist or gastroenterologist, then it's entirely reasonable to bring that up at that point in time, and it's a relatively quick fix in that sense. But certainly, if you're in the community and this is a new symptom, normally you would probably see your GP because some opticians will make a recommendation for you, but some might just direct you to GP anyway. And it's a relatively quick fix, as I say.
Super. GP is for that one. So now that this one, moving on to the topic of foods, actually. So it's come up about feeling sick. Can PBC make you feel sick after eating meals?
We don't think it causes this directly, but of course any chronic health concern does affect your gut health. So if you look at abdominal symptoms in PBC, remember the PBC the word cloud that you did as part of the PBC Foundation a number of years back, and abdominal pain came out quite strongly in that. So that doesn't automatically mean that PBC causes the abdominal pain, but it does have lots of knock-on effects that can make you more prone to getting abdominal pain. And as I say, if you did a survey of 100 people with various inflammatory or autoimmune diseases and a survey of people who don't have any of those conditions and no known health conditions, you will find abdominal pain occurs far more frequently in anybody who's got a chronic illness than somebody who doesn't have any chronic illnesses. Secondary, then, we know a lot of abdominal pain in the general population is related to gut issues, so often sluggish gut function. And one thing we see with PBC, of course, is fatigue. And if you've got joint pains as well with associated autoimmune conditions, that will reduce your mobility. And if your mobility is reduced, we know that has a really negative effect on bowel function and bowel emptying. And so you're much more likely to get a hold up within your bowels, get constipated and secondary pain from that. So we do see this quite commonly in people with PBC and other chronic illnesses, whereby the general effects of that on your body cause a generalized slowing down of gut function and pain associated with that.
That's a really helpful response to that question, because it's just, I think that would be helpful for a few things that are coming up. Another person's asking about carbohydrates. Are they harder to tolerate because of PBC? And they've heard conflicting information on this.
Yeah, they shouldn't be. I mean, it's PBC is a disease of the bile ducts, and the bile ducts excrete bile, and bile is, one of the main functions of bile is to help you absorb fats rather than carbohydrates. So carbohydrate absorption itself shouldn't be massively affected. Some people will have other conditions that are not directly caused by their PBC that can affect carbohydrate absorption, but PBC itself shouldn't directly or have a significant impact on the absorption of carbohydrates. And I think there's a question in the sidebar about bile acid malabsorption. And again, bile acid malabsorption is usually due to a primary gut issue rather than a primary liver issue. The liver processes chemicals and nutrients that are absorbed by the gut because the gut blood vessels drain into the liver through the portal vein and take all those nutrients to the liver for processing. But actually, the liver itself doesn't have a direct role in absorbing those things. Its role then is to store chemicals, facilitate other chemical processes through using those nutrients, and then to excrete waste products like bile. So the liver itself shouldn't have a direct impact on bile acid absorption. But if people have had other problems, if they've had their gallbladder removed, for example, then sometimes that can lead to diarrhea as a result of excess bile in the intestines, and the intestine isn't able to absorb the amount of bile that gets secreted into the intestines. Or if you've had an operation of your stomach or part of your small intestine where the bile acids are absorbed in the gut, then if you've had operations in those areas, then that can affect your absorption of it. So PBC itself shouldn't have a direct impact, but there might be indirect impact on other health conditions.
I love how much we're learning in these sessions. It's just fantastic. Thanks very much for that. Antibiotics is something that comes up as well, and thoughts on that in relation to PBC.
In terms of, are they safe or?
So somebody's actually asking that they've actually had taken them twice. They don't say which antibiotic, don't give me any more info than that, but they're just a bit concerned. Is it a dangerous thing for the liver when you have PBC?
So antibiotics, like any other drug, are toxins of sorts, or they have toxic potential. So and there's lots of antibiotics that can be associated with a drug-induced liver injury, and some are more associated than others, and there's huge lists of them. But there's some that are more classical to cause a drug-induced liver injury, and even those drugs, they do so relatively rarely. However, having a pre-existing liver condition doesn't make you more likely to develop a drug-induced liver injury. So if you have PBC, alcohol-related liver disease, or metabolic-associated liver disease, that doesn't significantly increase your risk. The risk of developing drug-induced liver injuries is largely genetically determined about how you handle that drug and handle that toxin. And so if, for example, somebody has a respiratory tract infection, in every hospital in the UK, there will be a protocol for what their first line and second line antibiotics are for treating that. And I don't modify that for anything other than if somebody has a known allergy. So, there's no specific antibiotics I need to avoid unless somebody is known to have an allergy with that. So we use the right antibiotic to treat the right infection, the more important thing. We shouldn't be avoiding the appropriate judicious use of antibiotics for fear of causing a drug-induced liver injury, because there's not an increased risk just because you have PBC.
Again, very helpful, thank you. Somebody's asking about liver transplant, and is there such a thing as a cut-off age in relation to liver transplants?
Yeah, it's a really good question, isn't it? So, I'm not a transplant hepatologist, but I've been around hepatology and referred enough people for transplant now over the years, and when you look at the referral criteria, there isn't an absolute cut-off, okay? But in general, once you get to the age of 70, and certainly 75, the incidence of other problems such as kidney function issues or cardiac issues or respiratory problems often mean that somebody isn't physically fit enough to undergo the rigors of the transplant operation. So there's not a hard and fast rule, but certainly above 70, you've got to be extraordinarily fit with zero other health issues to withstand the transplant process. And certainly over 75, it does become even more difficult again. But there's not an absolute hard and fast rule.
Thank you very much. Moving on to somebody's having shoulder pain and is wondering about steroid injections. Is it okay for them to have that with PBC?
Yeah, I think so. Steroid injections are different because they might have a little bit of non-steroidal in them, but they are usually cortisone type injections. So that's traditional steroids like prednisolone or variations thereof injected into the joints, and most of that doesn't get absorbed into the general system. And there are people with PBC who get treated with prednisolone for if they've got a PBC autoimmune hepatitis overlap, for example. So there's no reason why you can't have joint injections if you have PBC. And for some people, they can be, very much symptom relieving when they've got troublesome joints. So if it's clinically indicated, there's no reason why we can't. And we even have people with really quite advanced chronic liver disease who have said, yes, go ahead and have a joint injection if you're really struggling with your symptoms, because the likelihood of that causing any systemic problems is very, very low indeed.
That'd be very reassuring for that person. Thank you very much. Let's go on to exercise and weight loss, and somebody's asking about if the FibroScan score of F3 can it be reversed with exercise and weight loss? Anything to say on that?
So I guess the initial question with that is what's caused that FibroScan score of F3. Okay, so if you have a FibroScan score of F3 because of relation to your PBC, then potentially therapies bringing your ALP down might modify that. So F3 isn't always irreversible. It can sometimes improve. But if we just assume for a second in relation to this question that it's solely related to having fatty change within your liver, then we know that the weight reduction can lead to significant improvement in extraction of fat from the liver, and that will reduce the liver stiffness and in some cases the amount of liver fibrosis and therefore the FibroScan score will come down from F3 to F2 or sometimes even lower. So absolutely, yes, FibroScan scores can come down with weight loss, but it would depend on whether the weight gain and the fatty liver was driving that in the first place. Whereas if there was another reason for it, PBC, for example, then it wouldn't modulate your FibroScan score if all your fibrosis scar tissue was related to PBC.
Got you. Yeah, thank you. Still on FibroScans. So if it's gone from 20, this FibroScan went from 20.1 to 25.9. Curious as to, is there anything the person could be doing to stop it from rising? And there's a wee bit more info there about them experiencing itch, their own Osho and Oka.
Yeah. So I think we talked about, weight loss can modulate FibroScan scores. So, if you have gained weight, then weight reduction can help bring the FibroScan readings down. A FibroScan reading of 20 to 25, is obviously a reasonably high reading. And so it sounds like somebody's on appropriate treatment with Urso and Oka. If they've got ongoing itch, then they should be getting in touch with their team to make sure that their itch is managed. And again, I suppose there's, making certain they've had that conversation about what the implication of that FibroScan score is for them in, in the context and the knowledge of all their other information, like their other health conditions, what the other blood tests are showing. Have they fully responded to, ursodeoxycholic acid and Oka? Because as we know, there are other licensed therapies now approved for this, which will be available to patients in the UK probably by the end of December, if not January. So I think looking at the whole context, if your FibroScan score is going up, then the team needs to have a look at that and work out what the implication is for that person, and to make sure they're on the right therapy for them in the context of all these other bits of information.
So just making sure that they're in touch with the team, following up with them, and helping them understand, the picture of things better.
With all the relevant information that they would require to be able to have that, full discussion. Yes.
Yeah, super duper. This is one I've heard come up a few times, is hair dyes and studies that say different things. What are any thoughts to share on the use of hair dyes?
Yeah, the hair dye story is a very interesting one. I think when I first started getting interested in hepatology when I was a junior doctor, this is going back to the early 2000s, hair dye was very much implicated as a trigger for PBC based on a cluster of cases from Newcastle. And I think Oliver James and I think Dave Jones, I think, was probably working in Newcastle at that point as well. And there's a lot of interest in that. But I think it turned out that most of that association was actually familial links, and there were genetic tendencies. There was an area where there were lots of families living close to one another, and actually that was the cluster was familial clustering rather than an environmental trigger cluster. The reason why this sort of rears its head time and time again is that we know lots of autoimmune disorders can be triggered by an environmental exposure. So you have to have a genetic predisposition, which is why these conditions can run in families. But there's there's often or frequently a environmental trigger, such as a medication or a toxin that people are exposed to. So people have looked at this. There's been some interest in whether there seems to be clustering around old mining areas, for example. So is this in the water, heavy metals in the water, which are higher in concentration in old mining areas, such as where I live in South Wales and in certain parts of Yorkshire, in the northeast and parts of Scotland as well. Whether that's implicated, that hasn't been proven either yet. So we haven't identified a clear environmental trigger for PBC, I'm afraid. But the hair dye story refuses to go away, and it does periodically. But there's no convincing association.
Thank you very much. That's great. Let's have a look. The other one was, I've heard it come up lots of times, but just to remind people about coffee in the liver. Is anything to share there? What the benefits?
Yeah, well, as a coffee drinker, I'm going to say this, but I think what we see is an association. Okay, so we see an association with drinking 2 to 3 cups of coffee or more a day with a lower incidence of liver disease on a population basis. So that means if you take surveys of people and you sort of, and they often do these sometimes big population studies where they'll do questionnaires and then they'll follow up those people and see how many developed X condition and Y condition. And what we find is that people who drink more coffee do seem to have a lower incidence of liver disease. Now, what we don't truly know is whether it's the coffee drinking itself that leads to, is it protective against liver injury? And I'll come back to that in a second. Or is it just that coffee drinkers are less likely to indulge in other behaviors that might be risky for their liver on a population basis, like alcohol? Are coffee drinkers less likely to be overweight? We don't really know all that information. So all we can say is there's an association. In terms of a plausible explanation as to why drinking more coffee, and this is a caffeine it is, so actually tea, if you drink a lot of tea, you'll probably have a similar effect, because we think it's the caffeine element that does it, and it is caffeine in tea. But caffeine is an antioxidant, okay? And what that means is it absorbs certain toxins in the body. So chemicals that are oxidized are injurious to cells. They cause damage to lots of different cells. And so things that actually switch off or absorb those sorts of toxins can potentially be beneficial. But the actual link has not been clearly proven that it's definitely the caffeine that's doing it. But there is a potentially plausible theory by which caffeine with an antioxidant property might protect the liver from ongoing damage when these oxidant chemicals are floating around the system. And if the caffeine's absorbing those, it might be minimizing the inflammation. But I said it's still not conclusively proven, but there is a population association between coffee consumption and a reduced incidence of liver disease.
So if you're choosing from the shelf caffeine version, if you're going for decaf though, any
Probably no benefit.
Okay.
Go full fat.
Again, really helpful. And moving on now. So, sorry, we're back to FibroScan for a minute. Just somebody's had one in July and it was 10.5. Now they've said all their bloods were fine. They've not given numbers or anything like that. And they've said their consultant doesn't seem overly worried in next FibroScan in 2 years. And they're just looking for a bit of advice on that. That just doesn't give them much reassurance.
Yep. So I think the role of FibroScan in PBC is very much evolving. I think it's not been in the national international guidance, partly because it's not available absolutely everywhere, and I think we haven't had good quality data to show how that changes clinical practice or predicts outcomes. Although we know FibroScan scores can give you a guide to how the liver condition is progressing in lots of other disease areas. So we've extrapolated from those other areas that they will likely do the same for PBC. And so, there's lots of people who have PBC who still haven't had a FibroScan. This sort of new way of working is working its way through the system, but it can be a valuable way of providing information on the degree of scarring in the liver, because of course we don't biopsy to make a diagnosis of PBC any longer. So it is a useful tool to try and gauge where somebody is in terms of liver damage. So a FibroScan score of 10 is not at the cirrhosis level of damage. So that is why a recommendation has been made for 2 years. And
Okay.
regular FibroScan for PBC, I would make exactly the same recommendation in terms of interval for that, because PBC is not, generally speaking, a rapidly progressive disease, and 2 years sounds a very sensible, in the absence of an absolute guideline about the appropriate interval. 2 years sounds a very sensible interval to recheck it. The thing that's important in the meantime is if I think I said the bloods were normal, or bloods are happy.
Bloods are fine, it says, yeah.
So again, if the bloods are under control, then the FibroScan in 2 years' time becomes very helpful. If there's no change, then you've got effectively no progression of disease over that interval, and then you can repeat it at periods of 2-4 years, depending on how stable or how much it's changing, to continue to monitor for ongoing liver damage. But at a FibroScan of 10, I would agree. I would do it again in 2 years.
Yeah, I hope that's reassuring. Now, the topic of statins has come up. We've got various questions, and I can see one come in live as well on Facebook. So anything you want to say to people about statins in relation to PBC?
Yeah. If you need them, take them. So if they are recommended based on, GPs will use something called a Q-risk score, which is your risk of developing cardiovascular events, so that's heart attacks or strokes. And if you're recommended to take them on those basis, then yes, we would certainly advocate for that. There's a lot more anxiety around statins causing liver injury than actually happens. The risk of a serious statin-induced liver injury is 1 in a million. Okay, and when I say serious, I mean like being hospitalized with serious jaundice or life-threatening injury. It's not uncommon that liver tests can spike up a little bit on statins, but even that's relatively uncommon, and it quickly resolves if you reduce the dose or stop them. So if they're indicated, the long-term evidence is that statins can significantly reduce the risk of major cardiac events. And so if your GP feels you would benefit from those, having PBC would not dissuade me from recommending the use of statins. On a separate note, and this is a picture that is not yet fully clear, but there's been interest for a number of years about whether statins reduce your portal pressure. Okay, so portal pressure is something that goes up if you develop cirrhosis, and reducing your portal pressure can reduce the incidence of complications of cirrhosis. So there's been some studies which have suggested that statins might reduce your portal pressure. There have not been particularly large studies, and there are some ongoing studies at the moment to try and answer that question. But statins have some weird anti-inflammatory properties that might reduce your portal pressure. So watch this space. We might have studies in a couple of years' time saying that actually statins are good for your liver. At the moment, it's just a query about whether there may be some properties that may be beneficial. But if they're indicated for a cardiovascular risk reduction point of view, then absolutely people should take them. And having PBC, like with antibiotics, doesn't increase the risk of getting a statin-induced liver injury.
Thank you very much. Hopefully the people, as I say, quite a few have asked on that topic, so I'm just checking if there's anything I've missed from the statin stuff, and I think you've covered everything on that. Thank you. Moving on then, someone's due to start elafibranor, and they take rifampicin as well for itch, and it's just about timings because leaving the gap between them. So they take the rifampicin twice a day, in the morning first thing and last thing at night. So just thinking about when they would take their elafibranor, if you have any hints, tips.
Yeah, I mean, good question. I mean, I think I would always check with your pharmacist first of all around that, because they will have access to all your other medications as well, to make sure that you're not taking other things that can cause absorption issues like Questran and other things of that nature. But generally, basically, because people are often on lots of medications, I would generally discuss that with your pharmacist, because they would have more information on what else you're taking and what else might need to be avoided. But yeah, there are certain medications that you do have to take alone, and in which case you just have to take the other drug at an alternative time. But certainly the pharmacist should be able to give you bespoke advice, because they've got a list of all the other things you're meant to be taking.
And often an underused resource is the pharmacist.
Yeah, absolutely. Yeah. Absolutely. And they've got lots of really good practical tips of how to get around some of those challenges, because that's their area of expertise. So yeah,
encourage people to do that. So moving on to fenofibrate, somebody's worried about side effects.
Yeah. So fenofibrate, like with bezafibrate, the common side effect probably is myalgia or muscle aches. That muscle ache is more likely if you're already on a statin, so you do have to use it with caution if you're on a statin. That's one of the situations at PBC where you would be more cautious about using statins. But the myalgia usually goes away once you stop the drug, so it's a temporary and resolvable problem. And so yeah, it's something to be aware of. The other major thing that we see with the fibrates, both fenofibrate and bezafibrate, is it can cause a temporary increase in your serum creatinine, which is a measure of kidney function. But again, that gets better when you stop the drug. So if you're on those drugs, we normally recommend having a kidney function test check. But from a symptom point of view, the commonest one with statins is muscle aches. But not everybody gets it. But if you do get it, it can be quite miserable, and you may well have to stop the drug, because if you just stop it and restart it, it'll just come back.
And fenofibrate and kidney, keeping an eye on the kidneys, how often would they be keeping checking on that?
There's no set schedule. I mean, what we normally do is we normally recheck it several weeks after starting the drug, just to make sure the kidney function is okay. I don't think there's any evidence you need to keep checking them every few weeks, but certainly, I usually check in about between 2 and 6 weeks after starting the medication. And if things are okay, then carry on. Similarly, if you have very mild impairment of your kidney function already, you can still use the drug as long as you're monitoring it to make sure you've not seen any deterioration on the drug. So, yeah, I would say within a few weeks is usually fine.
Yeah, and if you haven't heard, you can get in touch and say, I'm due to get some bloods. Great. Just one that's come in live as well on bezafibrate. So leaflet says take after food. Does that mean I shouldn't have food for a while? And if so, for how long? And I know that can be tricky for people.
Yeah. So, I mean, generally speaking, most things will be absorbed within 1 to 2 hours after you've taken the tablet. So if you're taking it after food, well, you've already had some food, and then, you're probably going to be several hours until your next meal. So if you've had breakfast at, say, 8 o'clock, and you take the medication at, say, 9 o'clock, then there's no problem with you having your lunchtime meal.
Lovely, thank you. Have a look. Look here. So, I want to make sure we cover this one. So somebody has been on our show for 3 years, not responded, Ocaliva since start of this year, and numbers are coming down. So they did an endoscopy 3 weeks ago, and so they're getting mixed information afterwards. The person who did the endoscopy thinks it's portal hypertension.
Yeah.
However, the specialist thinks it might be gastritis. And so has asked the person, they're going to have a look at Helicobacter pylori. And just to, how could you get these two mixed up? And is there anything like next steps for them in terms of conversation with the clinician?
Yeah, so there's a number of different ways you can assess the severity of liver disease. So for most people with PBC, we'll look at the ALP response to therapy, and that just tells you what we call the biochemistry. That's the blood test response. But some people can have a dramatic improvement in that, but still develop some scar tissue within the liver. So this is where your FibroScans become helpful. Yeah. When your FibroScan is already quite high and in the cirrhosis range, then you can sometimes have an endoscopy to look for other features of portal hypertension, such as esophageal or gastric varices. Now, very often an endoscopist will say the words portal hypertensive gastritis or portal hypertensive gastropathy, but actually that can be very hard to distinguish between other types of gastritis. And so Helicobacter is a bacterium that can sit in the lining of the stomach that can cause a gastritis as well. So I'm always skeptical. I would never make a diagnosis of portal hypertension just on endoscopy suggesting portal hypertensive gastritis or gastropathy, because there can be other things that can look like that. So it's really important not to over extrapolate that. So I think checking for Helicobacter and what your FibroScan is can give you a good guide as to whether you've got portal hypertension or not. If your FibroScan is less than 15, you almost certainly don't have portal hypertension. So doesn't mean to say above that you definitely do, but below that you almost certainly don't. So there's lots of other things that can give you a guide, and so I would be cautious not to overcall or overlabel somebody as having portal hypertension just on an endoscopy suggesting portal hypertensive gastritis.
I'm sure that'll be really helpful. And I think, so it's following up with the clinician, following what they've asked them to do, and FibroScan could be really quite helpful if that's available.
FibroScan or other, self tests, other things can be available to gauge the degree of fibrosis, because there are some, there is emerging evidence to be able to correlate those test results with the likelihood of having portal hypertension.
Okay, thank you. Somebody's talked about having discomfort, and I've heard this of a few people, discomfort in my upper right side under the ribs and shoulder blade. And they're curious as to whether does this get better with ortho, or is it just something they need to endure as part of PBC?
As we were talking about abdominal pain earlier, there's usually other reasons for abdominal pain. And so because we don't think abdominal pain, because the liver has no nerve endings, okay? So only the capsule around the liver has any nerve endings. So the liver cannot really experience pain unless the outer capsule gets irritated or inflamed. And that's not something that happens with PBC, because the condition affects the very microscopic bile ducts within the liver, the big ones and the areas and the surface of the liver. So you wouldn't expect PBC to directly cause pain. So therefore, you wouldn't expect URSO to actually improve any of those pains. So I think a lot of people say, oh, you've got a liver condition, your liver sits in that right upper part of the belly, therefore any symptoms you get must be related to that. But that is just biologically, plausibly, it's not the case, and it's not really possible to link the two in that regard. So it's always important that other causes are explored. Common things are musculoskeletal, particularly people who have coexistent Sjögren's syndrome or other joint issues, or people can get disc problems, they can get spinal issues. They can have other things that can cause pain in the upper part of the belly and through to the back. So I would say I would not be keen to label that due to PBC, because it's not really biologically plausible, and it's important to consider other possibilities and to treat those appropriately.
Okay, so that would be a conversation with your GP?
Yeah.
Yeah, great. Thank you very much.
Musculoskeletal issues would be the commonest by far.
Okay. Righty-ho. So somebody's talking about I'm ANA positive on URSO and steady for 8 years, now have osteoporosis and fractures in spine, and has currently daily injections of Tymolus. Should I be regularly checked for prothrombin time and leptin? And they mention, if you can see in the notes there, just some stuff that they're taking, and then their question is, are ANA positive patients worse off than AMA? So I'd be curious as to what you say to that one.
No, I think so. ANA positive, not AMA positive. Is that what you're saying?
Yeah, that's it. Yeah.
So I'm assuming the person's probably had a biopsy, because it's if you're AMA negative, then it's fairly sometimes you can make a diagnosis based on other blood test parameters to make a diagnosis of PBC, but very often people have had a biopsy. The reason that becomes important is that gives you a degree of assessment of what the level of damage is to the liver. And actually what's more important is not whether your AMA or ANA is positive, is how high your ALP is, if it's elevated, and how much damage is there or not within the liver. Those are the factors that really determine your outcome in PBC from terms of liver disease complications point of view. So it's interesting, isn't it, that if you look at the value of the AMA level, so some people, when you look at it, if you've ever seen your own blood results, it says 1 in 80 or 1 in 160, 1 in 650, 1 in 1260. Those don't correlate with the severity of your PBC either. So actually there's not good evidence in autoimmune conditions that the level of the antibody that we measure in the blood is a strong correlator with the severity of underlying disease. But what is a robust indicator of severity of disease is the higher your ALP is, and the higher your FibroScan is.
Thank you, that's great. Somebody's been advised, so we talked about stomach and stuff, but bowel issues before they started URSO, and their hepatologist advised them to stop URSO for 2 weeks, and this has caused them some concern, and they're curious as to any tips or helping them understand the stopping and the starting. And
so, I mean, URSO is generally very well tolerated, but the commonest side effect is diarrhea. Sometimes people get bloating, and you could directly get some discomfort with that as well. So I think if that's considered to be potentially the trigger for that person, it's entirely reasonable to pause the treatment for a while, because if you think a drug could have triggered a symptom, the trouble is diarrhea and abdominal symptoms are very common in the general population, so they could have come on anyway. But if there's any doubt as to whether the drug has done that, it's reasonable in most circumstances to pause. And I certainly think pausing URSO in PBC is entirely reasonable, because remember, this is not a medication that leads to short-term changes. It's a drug that takes many, many months to have its peak effect. And it exerts its beneficial effects over years and decades, not days to weeks. So if there's a potential for that drug causing a significant side effect, I would contend it's entirely reasonable, having explained the rationale why, to hold off it, assess whether those symptoms get better, and if they do, then it's likely to be the URSO that's triggered those symptoms. But if those symptoms persist despite stopping the URSO, then it's probably not the URSO, and going back onto them is appropriate. But if it is felt to be the URSO, then there are multiple other agents now available. We can fibroids, there's obviously OCA and now elafibranor. So I think, those other therapies are licensed when people are either non-responders to urso or they are intolerant of urso.
Thank you. Somebody's asking about elevated parathyroid hormone result. Is this linked to PBC? And if so, what could I do about it, if anything?
Yeah, so essentially not directly, but again, it's one of those potentially associated conditions. Okay, so you get hyperparathyroidism. The parathyroids are tiny little hormone glands just sitting either side of the thyroid in the neck. There's 4 of them usually. There can be a few more, but usually there's 4. And they secrete this parathyroid hormone, which helps you absorb calcium, amongst other things. So if that level is high, sometimes the calcium is up. Sometimes nothing needs to be done. But usually follow-up, usually people will get referred to an endocrinologist, which are specialists who deal in hormone issues. And sometimes if that's associated with a high calcium as well, and you've got a diagnosis of primary hyperparathyroidism, then sometimes they'll recommend you having the parathyroid glands removed if that is indeed an issue. So yes, if you have hyperparathyroidism, that can be another autoimmune condition associated with PBC, but it's not a direct consequence of PBC itself.
Yeah, I think there's a theme going on today about the associated. I've got another one, but I think it's along that line. So somebody's newly diagnosed, it was August, with PBC. They're on our show, they've had a FibroScan, which also confirmed stage 4 fatty liver disease. Ultrasound scan confirmed inflamed gallbladder with sludge and multiple pulps. And just the question is about, are they all related? Anything you would say on that about follow-up with a clinician? Anything they should be asking?
So stage 4 liver disease, fatty liver disease, is usually relates to the degree of fatty change rather than the degree of damage. That's easy to say. And not all stage 4 fatty change leads to lots of damage, but obviously the FibroScan will also give you an assessment on the amount of damage as well as fatty change. Okay, but in general, if you have 2 potential things that can cause issues with your liver, it's weight reduction can be a good way of trying to keep that liver healthier for a lot longer. So weight reduction strategies would be really important if you've got significant fatty liver when you've already got another condition that can cause liver problems. In relation, what was the second part? It was fatty liver and
gallbladder.
So gallstones are more common if you have PBC. So PBC gallstones are very common in the general population anyway, particularly amongst females, and of course 9 out of 10 people with PBC are women. But PBC is associated with an increased risk of stones in the gallbladder, and if you're having symptoms of those, then some people will need a cholecystectomy, a gallbladder operation. Urso does potentially make gallstones a bit smaller, but not massively so. It was originally used as a treatment to try and shrink gallstones, and then we discovered that it was helpful for PBC. So that's how it was originally used for. But if you're having symptoms of gallbladder pain, suggestive of stones, which is characterized by severe upper abdominal pain, often go through into your back, sometimes with sickness, sometimes after food, especially fatty meals, but not always, lasts for several hours, makes you feel pretty rotten, and then it'll disappear and it'll be okay for a while until it comes back. Those sorts of symptoms in association with gallstones, then consideration of removal of the gallbladder is usually done. The other thing to say in regards to the comment about polyps in the gallbladder, it can be hard on ultrasound to identify true polyps because some stones can look like polyps. You just see a little shadow on the wall of the gallbladder, and it can be hard to differentiate between a stone and a polyp. But if the report says polyps, then normally speaking, we would follow that up to make sure those polyps are not enlarging. Because if polyps are seen in the gallbladder and they are enlarging, then that's another indication to consider removing the gallbladder, even if you're not getting pain from it, just to avoid those polyps growing and turning into anything worse in the stomach.
Thank you. Great, we're getting through so many, which is fab. Next one I've got here is somebody's seen questions on Facebook asking about PBC with a positive antibody, ALT, AST in the 200 to 400 range, but ALP is normal. you say a wee bit about that, the elevation of ALT, AST? Sorry, we're coming to the end of the session, but throw that one in there.
So the thing I would say is that if your ALP is normal, you always have to be very cautious about making a diagnosis of PBC. It's not to say it's impossible, but an elevated ALT is much more, with a normal ALP, is much more suggestive of autoimmune hepatitis, and you can sometimes get AMA positivity in that as well. So this is a group of patients who I'm not saying this person will definitely need a biopsy, but these are the sorts of people who often end up having a biopsy to differentiate between a PBC autoimmune hepatitis overlap or actually pure autoimmune hepatitis who happens to have a positive AMA. Because to reiterate, at the moment, the diagnostic criteria to diagnose PBC are an elevated antimitochondrial antibody and an elevated alkaline phosphatase. If you've got a normal alkaline phosphatase, we wouldn't normally go down the routes of considering PBC, but the AMA is probably the red herring there. So it sounds like the medical team need to differentiate whether it's the AMA that's the red herring or the ALT that's the red herring, and very often a biopsy is needed to differentiate between those two things to work out what the exact process is going on with the liver to target the treatment. And if there's bile duct injury, it'll be urso. If there's no bile duct injury and there's lots of inflammation, it'll be steroids like you'd normally do with autoimmune hepatitis.
Okay, thank you. Let me just check. We've managed to get through, would you believe, all the pre-submitted and a couple of the ones in the room as well. I can see another one there that's asking about anti-inflammatory gels.
As I said previously about non-steroidal drugs, so the one about celecoxib. So anti-inflammatory gels are generally much safer than oral anti-inflammatories, but they can still be associated with some of the same side effects. So you can get leg swelling if you've got cardiac or liver or kidney disorders, and you can still occasionally get stomach ulcers with long-term use of topical gels, although the risk is considerably lower than with tablet anti-inflammatories. But again, if you haven't got any other advanced clinical problems such as kidney, liver, or cardiac failure issues, and you're not at extremes of age, then anti-inflammatories can be very, very effective for some people. But if there's any doubt about whether they're safe for you, then it's important to have a chat with your GP because they'll have access to all your other medical records. But they can be effective for some inflammatory conditions. But with all these things, we try to recommend the shortest term use possible because they can all be associated with some degree of risk longer term.
Okay, that's great. How are we doing? We're just nearly coming to the end. How are you doing for time? Have we got time for another one?
10 more minutes, yeah.
Great, super. I'm going to talk really fast now. Is having had Epstein-Barr virus also diagnosed then with PBC at the same time 21 years ago? I feel like I still get pains in my liver as I did then. Does it return years later along with other symptoms of EBV? I know nothing about that.
Epstein-Barr virus, viruses can trigger autoimmune conditions. You certainly see that with autoimmune hepatitis, but other autoimmune conditions I have seen triggered by Epstein-Barr virus. It generally never leaves the body, Epstein-Barr virus, but your immune system usually brings it under control. But if you become immune suppressed for other reasons, if you're on drugs like azathioprine, or if you had a transplant and you're on anti-rejection drugs, that can sometimes allow Epstein-Barr virus to reactivate. If that is a suspicion based on appropriate symptoms, pain is usually not the most typical one, but there'll usually be lots of blood test abnormalities. You might get lymph glands up, for example. Then a quite complicated test called a PCR is needed to see if you've got active virus circulating in your blood. But there's usually other pointers towards Epstein-Barr virus reactivating. And if your immune system is not compromised by medications, such as anti-transplant, anti-rejection meds after a transplant, then the risk is actually pretty low. So once you've had Epstein-Barr virus, usually it sits there dormant in your body for the rest of the time. But if you are on those rejection drugs or other immune suppressants, then sometimes it can reactivate.
I don't know how to pronounce it. Hemocytopenia and PBC.
Okay.
How do you say that word?
Yeah, it's not a term we normally use, but I get what the person's talking about. I think they're talking about low cell counts, particularly low blood cell counts. So we do see that sometimes. It's most commonly associated with with people who have cirrhosis secondary to their PBC, although not exclusively. So I don't want to alarm this person if that's not the case for them, because there can be other reasons for your cell counts to be a bit low. You can be deficient in vitamin B12 or folate, for example, and that can also put your cell counts down. And vitamin B12 deficiency or pernicious anemia is another autoimmune disorder, for example. So if somebody has low cell counts, then appropriate other testing needs to be performed, looking for B12 deficiency, considering the context of whether, what's the severity of their liver disease. Do they have liver disease severity that might suggest that their cell counts might be low? So there can be indirect associations between PBC and low cell counts, but there's lots of non-liver reasons for it as well.
Okay, I think we'll leave it there. I think that's been absolutely fantastic. We got through so many, so helpful. And anybody, if you have got questions, do submit them to info@PBC Foundation. If there's anything that I notice on the Facebook when I go through it, I'll make a note of those, so you don't need to submit those. I'll do it for you. I'll make sure they're asked when we have the next clinician. So thank you very, very much for your time. As always, it's great. Thank you, everybody, for joining us. And this will be uploaded to YouTube as well for anybody that wants to go back and listen in to all those top tips and advice. So thank you very much. The information's been fantastic.
Thank you. All right. Take care.